Hello, nutrition scenarios in MRCS Part A exam for January 2021 exam course announcement. Go to our website www.mrcscourses.org. So simply, enteral feeding is the best as long as you have functioning GIT. Traditionally, suspected basal skull fracture, this is a relative indication for nasogastric tube. Other than this, any trauma patient is amenable to NG tube. ATLS protocol recommends that OGT, orogastric tube, can be inserted rather than NG tube. This is the nasogastric tube. And here is a funny picture about a skull base fracture patient, and the NG pierced the clivus at the back of the pharynx, leads to, here you can see the NG going to the spinal cord through the jugular foramen instead of the esophagus and stomach. To confirm the position of NG tube in the stomach, it is safe to feed and administer medication. You have to check two things, either the pH monitoring or chest X-ray. pH reading of the gastric aspirate must be below 5.5, or don't give any feeds or medication on it. Chest X-ray is the final last resort option to confirm the position of NG tube. Here is the pH monitoring. You will put one of these slides into a gastric aspirate by the Ryle tube and then compare it on these readings. It should be 5.5 or below, and these are the numbers. Or chest X-ray, and here you can see the NGN. If the enteral feeding lasts more than 4 weeks, so more permanent access should be required, like percutaneous endoscopic gastrostomy. PEG or percutaneous endoscopic gastrostomy, it is a small tube inserted percutaneously by the assistance of OGD, endoscopy. If you have esophagectomy, at the same surgery, we can do feeding jejunostomy. But if you have like this esophagectomy, we do feeding jejunostomy. But if we have esophageal perforation, this is an indication for total parenteral nutrition. And because this means you have perforation and unable to take the enteral feeding. What are other indications for TPN? Intestinal failure. Mainly when there is normal feeding is not possible, like in Crohn's disease, gastric or esophageal obstructing carcinoma, severe paralytic ileus, severe obstruction, or intractable vomiting. When food is incompletely reabsorbed as major burn, major trauma, and radiation therapy, ulcerative colitis, or chemotherapy and short bowel syndrome. This is intestinal failure. When food intake is undesirable, like post-GIT surgery in bariatric surgery patients, maybe, and in chronic inflammatory bowel diseases or intractable diarrhea. So these causes, or these are the indications of TPN. So you will be asked in your exam simple question about patient with esophageal perforation, and will give you MCQs, so you will choose total parenteral nutrition. If patient going to esophagectomy, like Ivor Lewis or Macron's esophagectomy, then feeding jejunostomy is the option. If a trauma patient, you will do NG tube. But if told you about this will last for long-term feeding, 4 to 6 weeks, more than this duration, then percutaneous endoscopic gastrostomy should be inserted. What is the how to confirm position of NG in the stomach, pH or chest X-ray. And pH, the gastric aspirate should be 5 or below 5. If you have suspected skull base, then orogastric tube should be inserted rather than NG tube. And enteral feeding is the best always. Thank you very much.